Everybody, this is Dr. Jennifer Cook filling in for Dr. Williams, who's traveling this morning. I want to welcome everyone to the Department of Medicine Grand Rounds at University of Louisville. And this morning, our Grand Rounds is being presented by our Division of Pulmonary Critical Care and Sleep Medicine. So I'll turn it over to our Division Chief, Dr. Mohammed Saad, to do our introductions this morning.
Thank you, Jennifer. Good morning, everyone. And it's my pleasure today to welcome Dr. Ashley Cattran from University of Cincinnati. Dr. Cattran got her medical degree from University of Cincinnati and stayed there for residency and fellowship. And currently, she's an assistant professor in the Division of Pulmonary Critical Care and closely working with Dr. McCormick there, of course, with the Sarcoidosis and the ILD program, their nationally recognized program. Dr. Cattran, if you look at her CV, had numerous awards and accolades at our college and medical school. So it's not a surprise that Dr. McCormick probably got her to stay in there. And we're fortunate today to have her giving us an overview of sarcoidosis for the internist, which is an important topic. As you know, we have our ILD program here, and we heavily interested into this ILD as an area. So welcome, Dr. Cattran, and thank you for agreeing to do this.
Thank you so much. Thank you for the introduction. Good morning, everyone. I want to thank everyone again for having me. I'm really excited to be here. I am second-year faculty at UC, and my clinical interest is sarcoidosis. I originally became interested in sarcoid because it's often poorly understood, and there's still so much we need to learn and discover about it, which it can be often very challenging and isolating for patients as a result. But we do know that internists and multiple other medicine subspecialists are often the first providers to encounter patients when they originally present with sarcoidosis. So I wanted to give a bit of a rapid review on what we know today and where we stand, and I hope it'll be helpful. I also want to apologize for my voice. I'm a little under the weather, which was not well timed, but it doesn't normally sound like this. So here are our objectives for today. I'll just let everyone read them. And I do not have any disclosures. So sarcoid is a multi-system inflammatory disorder characterized by the formation of non-necrotizing granulomas in various organs, most commonly the lungs. It is importantly a diagnosis of exclusion, and we have many theories that exist regarding the cause, but the exact trigger that sets off this abnormal immune response is still not known, which is sort of crazy when you think about it. We suspect that it's related to an environmental trigger in a susceptible host, and that there must be genetic factors that are involved, since it's certainly increased in certain groups. This is just a depiction of the complex pathway that is involved in the formation of sarcoid granulomas. I'm not an immunologist, and also is not the focus of today's talk because I wanted it to be more clinical, but it does demonstrate that there's a lot of complexity there in what could be contributing to the sarcoid pathway. Epidemiology is really important in sarcoidosis, and I suppose everything. But it really demonstrates the health disparities that exist in the sarcoid population. So I wanted to highlight two of the major epidemiologic studies that have been done in the US. This first one here is a study out of Henry Ford, where they looked at individuals in a health maintenance organization in the Detroit metropolitan area. This was from 1990 to 1994. And it was a good study. It was racially heterogeneous. It was individuals 20 to 69 years. And represented about 5% of the Detroit metropolitan area at that time. So this chart or graph demonstrates that by far the highest incidence occurred in African-American females. And on the right, there is a chart noting that the age-adjusted average annual incidence was 39.1 for African-American females, which is much higher than that in Caucasian females and males particularly. This is just another chart from that same study where it's broken down by age group. And this, I think, is really remarkable that in African-American females aged 30 to 39, we found the highest risk, where the average annual incidence was up to 107 per 100,000. But consistently in essentially all age groups, African-American females had new cases of sarcoid the most frequently. This is a second study. This was done by Dr. Baughman from Cincinnati. And it was a study done between 2010 and 2013, where they looked at the Optum Healthcare database, which is a large US insurance database, and it included approximately 15% of US residents. And it again noted that the highest incidence occurred in African Americans. And this just shows the bottom chart, part B, shows that Asians and Hispanics do, of course, still have sarcoidosis, but at lower rates than either African Americans and Caucasian individuals. This is from another paper that summarized several other epidemiologic studies. And we won't go through them all individually, but it just sort of highlights that the consistent trend is that African Americans have higher incidence of sarcoidosis. If you attempted to make some sort of an average of the studies, they concluded it was about 10.9 per 100,000 for Caucasians and 35.5 for African Americans. Other populations of note who have higher rates of sarcoidosis are Northern Europeans, and specifically cardiac sarcoidosis is common in Japan. Also very important to note that sarcoid incidence and prevalence are likely underestimated. And this is due to lots of factors, but one being that asymptomatic disease is really common. So that part is a good thing, but probably leads to us not knowing how many people actually have it. The second thing is that delays in diagnosis are very common. And this was highlighted by an autopsy study that was done in the 1990s in Northeast Ohio, where they found a much higher prevalence of signs of sarcoidosis on autopsy compared to death certificates, what was reported. It was actually 10 times higher. So the biggest take-home point is that sarcoidosis affects African Americans disproportionately. Why? In part due to the higher incidence, which is probably related to race-related genetic associations, but also socioeconomic factors. They have different disease phenotypes, and multi-system disease is more common. And we've also seen that FVC is lower in African Americans at presentation compared to other groups. And socioeconomic factors also contributes to this as well. Health disparities for sarcoid is an entire talk unto itself, but I did want to spend some time on it because it's really important and a good take-home message. This is another epidemiologic study called the ACCESS study. And in this case, they enrolled 736 patients within 6 months of diagnosis at 10 clinical centers in the US. And the goal was more so to identify organ involvement, but also other characteristics of those with sarcoid. And this chart is actually trying to demonstrate which findings they found were significantly different between different groups. And again, at the top, wanted to point out that this is the top portion of the chart, shows that African Americans much more commonly have multi-system disease. In terms of disease course, they did a 2-year follow-up to the ACCESS study, where they were able to track down 215 of the individuals from the first part. And they found that people with sarcoid generally do improve. 80% had improved or stable FVC, chest X-ray, and dyspnea scales, but there was less FVC improvement in African Americans, and they were also more likely to develop additional sites of organ involvement over that 2-year period. Here's another study looking at the characteristics and course of sarcoid. This was done by Mark Judson, Cleveland Clinic. And this is a retrospective analysis to determine clinical characteristics of 1,774 patients who were actually at MUSC over a 12-year period. So key findings were that delays in diagnosis, as we pointed out, are very common. It took over 3 months in many individuals and over 1 year in 25%. Most commonly was found in African American females. Treatment was required in 61%. And they also found that lung function generally improved over time, which is good. But compared to men, women had more advanced chest X-ray stages And compared to Caucasians, African Americans again had more advanced chest X-ray stages. They more commonly required treatment and they had more organ involvement. So we've had a lot of consistent findings in this regard. This chart, part A, on the left, is just demonstrating the higher chest X-ray stages for those individuals that are African American. I realized I didn't mention this elsewhere, but using stages for sarcoid X-ray grading is common. Many people may have heard about them. It's called the scatting stages. They've been around a long time, but stage 0 refers to like no abnormalities at all. Stage 1 refers to just hyaluradenopathy only. Stage 2 is hyaluradenopathy and parenchymal change. Stage 3, just parenchymal change, and stage 4, fibrotic disease. So stage 4 with fibrotic disease was more common in African Americans. And the chart on the right is just showing the increased rates of organ involvement. This is just a depiction of the fact that sarcoid can really affect nearly anything. I bolded pulmonary, not just because I'm a lung doctor and I'm biased, but because it's by far the most common. Again, just pointing out that the lung is the most commonly involved organ. It's actually in 90% or sometimes more than 90% of individuals, depending on the study. Skin, eye involvement, liver involvement, extrathoracic lymph node involvement is common and has been consistent across studies. This is one graph just showing that, how much more lung involvement there is compared to other organs. You can see that some severe forms of sarcoid, such as those with neurologic involvement or cardiac involvement, are less common, but there's still a significant portion of patients who do have those manifestations. This is a second study. This is also from the ACCESS study, showing the same, very consistent findings with the prior. In this study, they had 95% of people who were found to have lung involvement in that population. Mortality is also an important thing, of course, to think about with sarcoid. The most common cause of death related to sarcoid is respiratory failure. This is 2 studies also looking at the mortality rates, which in the first was found to be 2.8 per 1 million person years. They also found that notable findings were cardiac events and pulmonary fibrosis were common in younger patients. And the common trend between both was that mortality rates were higher in women and African Americans. So how do we diagnose it now that we've identified its importance? It can be really challenging, as I'm sure many people have already encountered. And this is for multiple reasons as well, but partially due to the wide spectrum of presenting symptoms. Symptoms can be so nonspecific. There are a lot of disease mimics, and we don't really have a standardized approach, partially because we need better approaches, but also because with multi-organ involvement, sometimes the presentation is somewhat unexpected. So how do we go about it? So this brings us to our first guideline statements that I wanted to highlight, because we do have 2 recent guideline statements, and it had been a while since any priors. For in terms of diagnosis and detection, which this from the American Thoracic Society is discussing in 2020, the one prior to that it had been over 20 years. So I wanted to go over these because it does give us something to go off of here. The purpose is really to provide standardized recommendations for clinical questions that providers commonly face. And it was made by a committee of experts from the ATS and other methodologists. Importantly, the quality of evidence was overall poor, which is a consistent trend we will see, unfortunately. Before we go into how, they needed to specify the diagnostic criteria. And the diagnostic criteria for sarcoid include compatible clinical presentation, non-necrotizing granulomas on biopsy, and I think the third is the most important, and that's to exclude other causes of granulomatous disease. We'll go through a representative case to help us with this. So first case is a 45-year-old female. She presents to clinic for a new patient evaluation. She actually initially presented to the ER for chest wall pain after a mechanical fall a month ago. The chest x-ray showed no rib fractures, but it was notable for hilar fullness, incidentally noted. Her medical history includes hypertension and obesity. She is a never smoker, and she does not have a family history of lung disease or malignancy. This is the chest x-ray showing some fullness in the hilar region, but otherwise pretty clear. They followed this up with a chest CT to better characterize what was going on and found some pulmonary nodules and somewhat of a perilymphatic distribution. So what is our next step? Should we repeat imaging in 4 weeks? No further workup? Should we do an EBIS, bronchoscopy, or should we refer for mediastinoscopy? Sorry, I don't have audience response set up or anything, but we'll think about them in our minds. So this brings us to our first recommendation. That was a major change in this set of guidelines. And it notes that for patients who do have suspected sarcoidosis and mediastinal or hilar lymphadenopathy, EBIS is the recommending lymph node sampling procedure, as opposed to mediastinoscopy, which used to be our test of choice. And it was low quality of evidence overall, but we have found that EBIS is pretty valuable and has approximately an 87% diagnostic yield in those with suspected sarcoid, and is obviously much less invasive. So this has become our preferred test for lymph node sampling. So that was what I felt was our correct choice here. This is what the biopsy looked like. You can see this is a granuloma. It's a non-necrotizing granuloma, which we see more typically with sarcoid. So this is our official results. The cytology shows well-formed non-necrotizing granulomas and no evidence of malignancy. BAL showed negative fungal and acid-fast cultures at 6 weeks, so we've ruled out our infections. And flow cytometry did not show any abnormal immunophenotypes concerning for lymphoma, so it's good there. At this point, we can consider the diagnosis confirmed, and that's because we've met our 3 criteria. We have a compatible clinical presentation with bilateral hilar lymphadenopathy and pulmonary nodules and a perilymphatic distribution, which is very typical for sarcoid. There are non-necrotizing granulomas from our biopsy, and we've excluded other causes in general. No infections and no lymphoma, etc. This brings us to our next question. So do we always need a biopsy? The answer is most of the time. And I think that's important because presumptive diagnoses of sarcoid can lead to problems. So in general, we do want a biopsy. There are a few exceptions, and there are these clinical syndromes, which we'll click through. And the reason that they are excluded is because they've been found to be so consistent with sarcoid that the suspicion for having another cause is very low. And so if you have these syndromes, you can make a diagnosis without a biopsy. So our first is Loughran syndrome, probably the most well-known, which is the triad of bilateral hilar lymphadenopathy, erythema nodosum, or these kind of red, round spots on the legs, and especially the shins, and arthralgias, and sometimes fever. Lupus pernio, which are these plaque-like, indurated, often disfiguring lesions on the nose and especially the nasolabial area. So this is very typical for sarcoid, often requires somewhat aggressive treatment. And the last is Herford syndrome, probably seen less, but includes the triad of keratitis, facial nerve palsy, and uveitis. And that's just a CT scan showing keratitis, which is actually quite common in sarcoid. What about totally asymptomatic bilateral hilar lymphadenopathy? Not causing any problems. Do people with that need a biopsy? Based on the ATS guideline, they concluded no recommendation for or against. This is because it's a little tough. When you take all comers with asymptomatic bilateral hilar lymphadenopathy, sarcoid turns out to be the diagnosis in 85% of cases, but the other remaining cases where it was not sarcoid were lymphoma or infection. So those are obviously big misses. And some procedures were non-diagnostic as well, contributing to these numbers. So it has to be taken on a case-by-case basis in this case. This is just a summary of the diagnostic recommendations from the guideline. And again, we discussed these. There are certain syndromes you don't need a biopsy for. Not a clear answer for asymptomatic bilateral hilar lymphadenopathy. And if you do have a need for lymph node sampling, EBIS is the preferred procedure. It doesn't obviously apply to every case of sarcoid, really only does with certain scenarios. So clearly it doesn't give us a perfect answer for everyone with other extrapulmonary involvement, for example, but I think it's a helpful start. So back to our clinic visit. She's here for a follow-up. Patient reports that her chest pain near the site of impact from the fall has resolved. She denies dyspnea. She does not have a cough. The review systems is otherwise negative. You've asked a full review systems, everything's negative because you're screening for extrapulmonary stuff. The exam shows that the lungs are clear. It's otherwise unremarkable. You don't see anything on the skin, stuff like that. They're very prepared. PFTs were done before the appointment and showed overall normal findings. No obstruction, no restriction, diffusion is normal, and the vital capacity is 97% of predicted, so that is great, very normal. So what do we do now? Do we start prednisone? Do we start methotrexate? Do we not need to treat her? Or do we need to get more information? This is what I feel the answer is, which brings us to our next point from our ETS guideline, which is what screening tests are recommended at the time of diagnosis. This is important because it's screening for asymptomatic involvement that we otherwise might miss. So there's actually not a ton. So this is for anyone who has a new diagnosis of sarcoid. This is just a baseline set of tests that you get in the absence of symptoms. Everyone should get an eye exam, an EKG, and lab testing. And you're really looking for a renal panel for their creatinine, calcium level, hepatic panel for the alk phos specifically, which is the most common abnormality we'll see with liver enzymes in hepatic sarcoid, and a CBC to look for any sign of like bone marrow involvement, for example, with cytopenias. This is important because if you do find some asymptomatic disease, like you find early uveitis or hypercalcemia that hasn't yet caused them kidney stones or other problems, it can really change your treatment plan. So these are our baseline tests. This just brings us back to our organ involvement slide, showing that that's kind of just some of the areas that these screening tests are targeting, but it's hard to reach all of them. This is just a plug for uveitis, which can be a really big problem for a lot of patients with sarcoid and is a common manifestation. It can cause a lot of inflammation in these parts of the eye, and common symptoms would be like eye redness, eye pain, blurry vision, and can even progress to the point of causing blindness. So super important to screen for and recognize, especially if they have symptoms. This is just things we might be looking for in an EKG, like signs of heart block, or in this case, just PVCs. But obviously our biggest concern with sarcoid is ventricular arrhythmias. So might give you some clues there. And then there really were not a ton of others big recommendations from that guideline aside from these 4 that focused on cardiac testing and pulmonary hypertension. And important take home for any concern for cardiac sarcoid is that if you do have any abnormalities that make you think someone might have it, not for asymptomatic patients, but if you have a concern, cardiac MRI is the recommended screening test, and that's because it's found to be significantly more sensitive than either echo or PET, cardiac PET for sarcoid purposes. If there's no cardiac MRI available, PET is preferred, and we're basically looking for areas of abnormal uptake in the heart that could suggest granulomatous inflammation there. And for pulmonary hypertension, somewhat intuitive, but first screen with an echo, and then if it's abnormal, get a right heart cath to confirm your diagnosis. So here are the results for our patient from our additional evaluation. EKG shows normal sinus rhythm, renal panel and calcium, hepatic panel, CBC, they're all normal. And she got an eye exam, which was normal. No sign of uveitis or any other findings. So do we treat? What now? This brings us to our next recent guideline statement, which are guidelines from actually the European Respiratory Society in 2021. And there's obviously a series of experts who were involved in their development there. This is, I think, my own personal take-home point for the guidelines is that treatment decisions need to be made based on risk of death or organ impairment and impairment in quality of life. And this is because, as we'll get to, our treatments are by no means perfect, and they all have big negatives associated with using them. So we want to decide if people need treatment based on risk for progressive organ impairment or death and impairment in quality of life. This is just their first question that I put in here because it relates to our patients. So in patients with pulmonary sarcoid, should steroids be used versus no immunosuppressive treatment? And they concluded that if there's major involvement from pulmonary sarcoid and higher risk of mortality or disability, introduction of steroids is recommended to improve or preserve FVC and quality of life. So how does that apply to our patient? I think she has normal PFTs. She has no to minimal pulmonary symptoms. She would be lower risk of morbidity. She has no change in her quality of life. And so I think it's reasonable to monitor clinically at this time, but it needs close clinical monitoring to ensure that there's no progression that might change things. So this is a big summary of our treatment approach. It's like simplifying it a lot, but first line, steroids, strong recommendation. Second line, methotrexate, the preferred agent. Conditional recommendation. Third line, infliximab, which is a TNF inhibitor. We'll get to that too. It's a conditional recommendation. This is a nice treatment algorithm that is given by the ERS guidelines. It basically walks you through, and this is for pulmonary sarcoid. And a lot of our treatments are extrapolated from data for pulmonary sarcoid specifically. But so this chart notes someone has pulmonary sarcoid, you have to assess the need for treatment. You have to classify them as low, intermediate, or high risk. And then if they are intermediate or high risk and have impaired quality of life, then the first step is steroids at the lowest possible dose. If you have persistent disease, relapse, or too many side effects from steroids, go to our second line agents. Preferred agent being methotrexate, but there are other oral immunomodulators as well listed there that we'll go through. And third line for continued disease or relapse are the TNF inhibitors. And in all cases, you're trying to taper your steroids. And that's the green boxes in the middle. So what do we take from this? Is it that steroids are the holy grail for sarcoid, or are they not? I know this is not a surprise to anyone. The general idea is that there's a bit of a love-hate relationship with sarcoid and steroids in general, and lungs. The pros are that they have a ton of short-term efficacy, which our other agents really do not. The oral immunomodulators can take months to take effect. So steroids, quickest acting, they do lead to clinical improvement in studies. They do lead to radiographic improvement and some improvement in PFTs based on our available controlled trials. There's not a lot of data on long-term efficacy, really, but in the short term, that's what they've been shown to do. Also, not a surprise, I think everyone knows about the steroid side effects, which are huge. We create an entirely new set of problems in a lot of our sarcoid patients who need steroids for a long time, such as weight gain. They'll become diabetic, causes hyperglycemia, hypertension, long-term. Tons of people have osteopenia and osteoporosis, cataracts, easy bruising. Mood changes are huge. Sometimes hard for people to tolerate the steroids for mood changes and sleep reasons. So this is very important. Still our first line. Despite this being our first line and only truly FDA approved treatment for sarcoid, things that we still need more information on include more accurate risk stratification of our patients. What are PFT thresholds that might suggest treatment could be needed? Do we use steroids alone versus in combination upfront with second and third line agents? What dose do we even need? How long do we give them steroids? How do we taper it? And are low dose steroid regimens effective? Here's just a chart from the same guideline paper about a summary of some of these agents, their dosing, their toxicities, monitoring, and comments. We won't dwell on this side specifically, but just highlighting all of them have significant adverse effects. So let's go through them quickly. We won't dwell on this too long, but I do want to go through why we do some of these medications, what evidence we have. First is methotrexate. As I said, this is our preferred second-line agent. We have by far the most experience with this for sarcoid, other than prednisone. When do we use it? As mentioned, symptomatic disease, high risk of mortality or disability, who had persistent disease despite steroids, we could not wean them, or they could not tolerate the steroids. There's actually not as much data as you would think, but a small randomized control trial showed that there was a reduced amount of weight gain and there were reduced steroid doses when it was used, and it showed improved lung function in smaller studies. This is just a quick reminder to make sure patients that you have on methotrexate are taking folic acid daily, and that is because of methotrexate's interference with dihydrofolate reductase. So that's an important thing we all should be making sure of. Second thing I wanted to mention was azathioprine or Imuran. This actually did have a retrospective study comparing individuals with sarcoid on methotrexate versus Imuran. They looked at data over 2 years and found similar steroid-sparing effects, similar in slight improvements in lung function, but there were higher infection rates with Imuran in this study. Mycophenolate or Cellcept. I'm not going to spend much time on this or the next one because there's very little data, but retrospective studies have shown that also can lead to a reduction in steroid dose and a trend toward improvement in DLCO. And the last one, second to last one I'll mention is leflunomide or Arava, which has been shown in a couple of very small studies to be similar in effectiveness to methotrexate and have small improvements in lung function. So you may be asking yourself why we use these with such poor data, but it's because we end up cycling through a lot of these different treatments because they do cause so many side effects and patients have so many flare-ups that we end up needing to switch agents. So that's why some of these end up being used despite the fact that methotrexate would be preferred, just kind of by function of needing another option. Plaquenil or hydroxychloroquine, used more so for skin disease and hypercalcemia. That's more of a thing in the collective experience. It's very helpful for those two things. Variable data, although there are some ongoing studies, but it's generally not used for severe pulmonary disease or cardiac or neurologic. And importantly, it's important to get yearly eye exams because of the retinopathy risk. And it's more so with dose dependent and duration dependent effects. So the longer and the higher dose you've been on over a period of years, the more risk of retinopathy. So it's overall a low risk, but if you're on it a long time, it's significant. And if it happens, it's significant. So it's real important to get yearly eye exams, approximately yearly for these patients. People do a variety of things. Sometimes people do 6 months, 1 year, 2 years, but on average, yearly eye exams. TNF inhibitors are third line class. These are important. These are being used with increased frequency for sarcoid. They've been shown to be pretty effective in smaller studies. The two examples are infliximab or Remicade and adalimumab or Humira. Remicade being much more common and well, both for other rheumatologic diseases, Remicade for Crohn's, etc., Humira for RA, but increasingly used for sarcoid. Again, I don't want to go through this whole pathway, but I did circle the two TNFs in the diagram, kind of highlighting that TNF alpha is involved in both the initiation and the maintenance of granulomas. And so that was one reason that led to it being targeted for therapy. So this was our first randomized control trial, and sort of only, that really showed some positive effects from infliximab in chronic pulmonary sarcoid that led to its increased use. So this was a phase 2 multi-center double-blind randomized control trial by Dr. Bachman and others, who took 138 patients with chronic pulmonary sarcoid, gave infliximab 3 or 5 mg/kg or placebo for 24 weeks, and looked at the primary endpoint of change in FVC and some secondary endpoints of dyspnea scores and walk distance, and basically found that there was, in fact, an improvement, a small improvement in FVC at 24 weeks in the combined 3 and 5 mg/kg infliximab groups. It was small, was 2.5% at 24 weeks, and there were no change in secondary endpoints, but it did lead to this being used for pulmonary sarcoid and has since had increasing data for extrapulmonary uses, especially skin and eye disease is real common for that. So now our patient comes back to clinic after 2 years, she's reporting increased cough. She said she's doing fine for a while, so she didn't follow up until now. But she's possibly noticed some increased dyspnea. She's doing her activities and still active, but still maybe a little more. She feels like something's off. No new extrapulmonary symptoms, just the cough. And her PFTs, however, do show that her FVC has dropped to 2.7 and her DLCO has dropped to 79%. So that would be a significant decrease. So this is her CT now. And in contrast, she's now developed increased nodularity in a perilymphatic pattern, as well as some fibrotic disease. So significant progression from 2 years prior. So what now? Do we give prednisone 60 milligrams daily, prednisone 20 milligrams daily, methotrexate and folic acid, or no treatment? So this is tricky. At this point, I think it's reasonable to say she needs treatment because her quality of life is worse and she has PFT abnormalities and has developed fibrosis. So certainly higher risk for morbidity and mortality at this point. In terms of dosing, there's no perfect data, but in general, which we'll go through a little bit, lower doses are thought to be pretty effective, and I think 20 milligrams daily would be reasonable. I will say it would not be unreasonable to start prednisone and methotrexate at the same time because she has comorbidities of hypertension and obesity, so will have significant side effects, and she also has already demonstrated that she's progressed to fibrosis, so may be more likely to require long-term therapy. So these are a couple of studies, and there's another one that I haven't added yet that just came out, also highlighting that lower doses of prednisone are actually probably okay, because previously people ended up on 60 of prednisone for prolonged periods, very long taper periods. But in these two studies, both retrospective, they, in the first, treated those with acute exacerbations with 20 milligrams of prednisone or less and found that spirometry improved to baseline. And in the second, analyzed prednisone dose versus changes in FVC and weight, and basically found that the dose did not affect the change in FVC, but it did affect the weight increase. And there was not a difference in need for second or third line therapy. So in all of these, it's led to the consensus that in most people, 20 milligrams of prednisone a day is likely adequate, but it's best to allow 3 to 6 months to really fully determine response. The taper period on average, about 3 to 6 months. One thing that we don't know for sure would be, should we use higher doses for those with high risk or severe disease, lower doses for those likely to have toxicity, or do we need higher doses depending on weight? Those are sort of things that vary between clinical practice, but I think it's important that 20 milligrams of prednisone in most people for pulmonary sarcoid is likely adequate. This is different for cardiac and neurosarcoid. This is just an example of what we're trying to prevent, severe fibrotic pulmonary sarcoid. So this is why when people have demonstrated progression or symptoms, that treatment is the goal, is to avoid this happening, because individuals with fibrotic disease have higher risk of mortality and higher risk of developing pulmonary hypertension as well. So I wanted to spend most of the time on pulmonary sarcoid, but we're shifting gears a little bit to something that I think is really relevant to internal medicine, especially like general internists and really anyone. Hypercalcemia is really common in sarcoid, and it's actually the most common cause of having chronic renal dysfunction. It contributes to the formation of calcium oxalate stones. You can also get hypercalciuria. And there's multiple mechanisms. We're going to focus on the first one, which is that hypercalcemia can be mediated by having an increased amount of 1,25-dihydroxyvitamin D or calcitriol. But other mechanisms that have been postulated are the increased expression of PTHrP in sarcoid macrophages and inflammatory mediators that can cause it to be higher. So again, the mechanism for the increased amount of 1,25-dihydroxyvitamin D is that there's increased conversion from cholecalciferol to calcitriol via alpha-1 hydroxylase, which is produced by macrophages and granulomas. And this is just like a general picture about calcium metabolism, but the top part in the top left is just demonstrating that in granulomatous disease is not specific to sarcoid, but including sarcoid, is that you get more 125 vitamin D from that enzyme in the granulomas, and it causes you to hold on to more calcium from the gut, have more calcium in your blood, and that's what can contribute to your hypercalcemia and potentially kidney stones. So let's do a brief little case to kind of illustrate this. Our patient is seeing PCP 10 years later. She didn't have good follow-up. She's been on chronic prednisone. She never got any methotrexate. She had her vitamin D checked, her 25 vitamin D checked, or cholecalciferol. It was 13 and low. The PCP is very understandably concerned for bone health because she's been on chronic steroids. Should you order a vitamin D supplement, excuse me? Not super easy answer. And this at the bottom that I have here, this would just happen to actually be my patient's vitamin D levels when I had open while I was making this lecture, but very common to see this where you get a low 25 hydroxy vitamin D, but a upper limit of normal kind of range, or even elevated 125 dihydroxy vitamin D. So we don't have great data on this, but the thought is that these people could have an increased risk for hypercalcemia if supplemented. So the ATF guideline did mention this as well, and the really gist of the recommendation was just to at least check both and think about it, because it's not straightforward and we want to avoid risk of hypercalcemia. In my practice, my pattern is to avoid supplementing if there's at least an even remotely recent history of hypercalcemia, or if they already have renal dysfunction. I think it's reasonable to supplement if you're monitoring labs and they don't have a history of hypercalcemia, but it's not always straightforward. So I just always recommend thinking about it and considering checking both levels. So how do we monitor disease activity? For example, in our patient, let's say she's developed this fibrosis over the years. How do you know if it's active or if it's burnt out sarcoid? And in general, how do we monitor disease activity in our patients? It can be tough. Of course, we use clinical parameters such as symptoms, PFTs, imaging, physical exam, depending on the organ, other organ-specific testing. But what about ACE levels? Isn't that the lab that we check for sarcoid? So just briefly, so ACE stands for angiotensin-converting enzyme. Obviously has multiple functions and involved in blood pressure regulation, but it is a dipeptidase which can also be produced by an increase within granulomas, which is why it's relevant to sarcoid. It was initially studied by J. Lieberman in 1975 and was found to be increased in patients with sarcoidosis. This spurred a lot of research on the matter, and it did show that it was consistently more elevated in patients with sarcoid. So it was initially recommended by sarcoid experts in the 1980s on their own consensus statements for clinical monitoring at the time. But evidence has really evolved over the years. The truth about ACE is that studies have shown mixed results. All of them show variable sensitivity and specificity. It does not consistently correlate with disease activity, and it really does not seem to correlate with disease severity or chronicity. So I acknowledge my bias in this regard. I'm really not a fan of ACE levels, but the reason for that, this is one study that summarized a bunch of what they called large studies, including more than 50 patients who looked at ACE levels in patients with sarcoid. And towards the right of the table, you can see how many patients there were with sarcoid and how many number and percentage of those patients had increased levels. And the range is huge. So it's anywhere from the 40s, 40% range to 80s. And so that's just a really large variation in the results there. And this is another kind of review article on biomarkers in sarcoid that lists a bunch of different markers, with ACE being at the top. But you can see there, they quote the sensitivity at 22 to 86% and specificity 54 to 94%. So to me, it is just not good enough to really make clinical decisions. It is a data point that potentially you could use, but I rarely check it because I don't think we have enough evidence that it's a consistent enough marker to actually help us make clinical management decisions, and certainly not for disease monitoring. So that is my practice pattern. And I did want to highlight that in general, we desperately need some sort of disease marker that perhaps could apply to different types of organ involvement and gives us something to go off of. But unfortunately, right now, it's a work in progress, but we still don't have anything perfect that has really great numbers for both sensitivity and specificity. So this is an ongoing research need. So what's on the horizon for us in sarcoid world? Big thing is we need better treatments. Why? I think it's obvious based on what I presented, but the data for our current therapy is weak. Prednisone is really the only standard treatment that's FDA approved for sarcoid. Everything else is used off-label, which creates huge reimbursement challenges and headaches for us, but most importantly for patients. It's hard for them to even get some of these medications that we want them to have. And whether or not we know that they've already failed multiple treatments, we rely on the insurance companies to approve or not approve an off-label treatment. So at Cincinnati, we're currently enrolling for 3 multi-center randomized control trials on new therapies for sarcoid. So I'm mentioning those here. There's lots in the works. These are some of the bigger multi-center ones. And this includes first efzofitimod. This is a neuropilin-2 inhibitor, which basically is an immunomodulator that is involved in the sarcoid granulomatous inflammation pathway. The second is namilumab, which is an anti-GM-CSF antibody for sarcoid, another target in the pathway. And the third is XTMAB16. This is another anti-TNF agent. It's not supposed to be the same. It's not like it's biosimilar to infliximab or anything like that, but it's still a TNF alpha inhibitor. And the benefit to this, if it were to be successful, would be that it could be specifically FDA approved for sarcoid, of course, way down the line if the study goes well. But this on the right is just another diagram of how complicated the pathway is, and there's a bunch of different targets listed there and arrows to what various studies that are ongoing are actually targeting. This is taken from a study or a paper by Dr. Baughman about kind of emerging therapeutic targets. So there's lots of things in the works, which is really exciting. And these are some of the ongoing multi-center trials that exist. Think about this for your patients. If you happen to have anyone, the general idea is that it's for pulmonary sarcoid, specifically in patients with active but not too advanced or too fibrotic disease. So these things I did not really discuss, but they're very important. It's just that they're topics for an entire lecture, like cardiac sarcoid, neurosarcoid, which both cause significant morbidity. I wanted to briefly mention sarcoid-associated fatigue. Fatigue and pain, despite that it's most commonly a lung disease, fatigue and pain are probably tied for the most common symptoms with dyspnea and cough. It's huge for these patients. It really affects their quality of life. Fatigue is hard to treat. Fatigue, first, we try to treat active disease if it is in fact active. Second, recommended is pulmonary rehab. And third, there's some mention of trying things like modafinil, but it's really not well validated. So we don't have a lot of good answers for this either, and it needs more research. Obviously, also a high overlap with comorbidities resulting from the steroid use that might put people at risk for sleep apnea. So that's another thing to think about. In small fiber neuropathy, just something to think about if you have a patient with sarcoid with kind of unusual pain or sensory changes, sometimes temperature changes. It will not show up on an EMG and requires other specific testing, such as a skin biopsy to try and diagnose it. But these are all things that can cause significant burden for patients and are just topics for an entire lecture. So this is my general conclusion. Sarcoids disproportionately affects African Americans. Steroids are a first-line treatment, but they have significant toxicity. Please check 25 and 125 vitamin D in sarcoid patients before supplementing. ACE levels do not have adequate data to support use in real clinical decision-making, and future research is on the horizon as we have a big need for more effective treatments with less toxicity. And I would be happy to take any questions.
Thank you very much, Dr. Cattran. Anybody has any questions? Let's see if there's any written questions here.
It looks like there's one question in the Q&A section. It says, would you treat a patient with only elevated ALP without pulmonary symptoms or disease?
It's a great question. I think hepatic sarcoid is hard. If we are saying that ALP is most likely elevated due to hepatic sarcoid, a lot of times we will monitor those patients if it's a mild elevation, because we don't necessarily have good data that always progresses to like long-term liver damage. So it's a bit of a judgment call. Some people will use your ursodiol if people have symptoms like they're itching or other things from the elevation. But in general, we would consider the just isolated, somewhat elevated ALP to be a lower risk feature than having like your AST and ALC elevated as well.
And we have a raised hand, Dr. Stoddard from our
Yeah.
cardiovascular medicine group.
Yes, thank you very much. I had two questions actually, or comment actually, on the issue of sarcoidosis relative to using echocardiography. One of the things is to consider is the emergence of what we call strain analysis, speckle tracking. So you can detect myocardial disease that you can't otherwise detect by just a qualitative or even ejection fraction. So I would put echo still back on that arena for at least early detection of myocardial disease. Just put that out there as a comment. The second thing I wanted to note, it looks like the data you talked about is very limited in terms of treatment options and what's going to solve sarcoid. Sarcoid has been around so long, and it seems to be that we're still in the same. Do you think, and this is a twisted question, do you think the fact that it affects women, number one, and also African American women, that there's just not that interest to put fuel money in there to figure out which way we can treat this illness in a better manner? Do you think there's any social factors there in that regard? So this is a loaded question for you.
Yeah, no, thank you for your comment on the cardiographic option. That's interesting. I'll read more about that. But also I think the social factors have been huge for sarcoid over the years. It also skews our data because the ideal research study would include the representative amounts of women and African American patients as how many actually have sarcoid, but that's not always the case. So I think that's been huge for our research studies, the results of our research. We've found consistently that they may be like those groups are less likely to be involved in our research studies for multiple reasons, like perhaps distrust of the healthcare system, et cetera. So I think it's been huge. I think it's getting better. There's like increased awareness, and we have some advocacy groups like the Foundation for Sarcoid Research is doing big things for that. So I think it's improving, but I think you're exactly right. I think that's been big over the years. It's been one limiting factor among others.
Any other questions from anybody? Well, thank you very much, Dr. Cattran. It was very informative. I appreciate you taking time to give us an overview of the sarcoidosis. I appreciate your efforts here. Thank you very much. I think we're going to do the cardinal minutes. Is that correct, Jason?
Yes, in just a moment. But also, Dr. Cattran, we have a tradition here at UofL that for our guest speakers, for our guest speakers, even virtual, we have a little gift for you that's very synonymous with the city of Louisville, and so you will be receiving your very own personalized Louisville Slugger bat.
Oh wow!
So
that's amazing.
yeah. So you can go help Ellie and those guys next spring. So
great, thank you so much.
So,
thank you for having me. I really appreciate it.
no problem. Thank you. And so thank you, everybody. This was our last grand rounds for the fall semester. We will be back on January 4th. Dr. Faraz Rahman from our cardiovascular medicine division will be presenting, and we'll see you guys then. Hope everyone has a great holiday season, and we'll see you soon. And so what we're going to do, Dr. Cattran, Dr. Saad, Dr. Cook, I'm going to go actually close this meeting here.